The topic of this presentation is turning off life support, how the decision is made and how dying unfolds. Currently in Australia, whole brain death must have occurred for a person to be deemed legally dead. This means that neither brainstem function nor cerebral blood flow may be present. In order to determine whether brain death has occurred, confounding causes such as disruption to sensory motor pathways or presence of barbiturates in the bloodstream of the patient are not the reason for reduced arousal, awareness and/or interaction. Patients must be observed over a minimum of 4 hours, during which time they remain unresponsive to all stimuli and with a Glasgow Coma Scale score of 3 or below. Brain death testing must be carried out by 2 independent and qualified medical practitioners. The testing cannot occur simultaneously but can take place consecutively. Importantly, the testing must establish whether there is sufficient brain pathology present which was sufficient to have caused death. The cerebral angiography here shows an absence of blood flow in the cortex in the right-hand picture. PET scans, fMRIs and CT scans are other tests which can demonstrate brain function or lack thereof. Observation of body temperature, blood pressure, neuromuscular and reflex functions are also assessed. There must be an absence of all brain reflex responses to all stimuli, as well as the absence of brain stem reflexes and breathing efforts for brain death to be determined. As you can see from this flowchart, there are a number of possible outcomes following a brain injury which results in coma, depending on the level of recovery. The various states of consciousness include vegetative state, minimally conscious state, locked-in syndrome, coma, and brain death. Vegetative state has a sleep-wake pattern, however reflexive motor activity only, with no indication of conscious awareness of self nor environment. After 4 weeks, it is considered to be PVS, persistent vegetative state, which is also known as unresponsive wakefulness syndrome. A very famous case of a person with PVS is Terry Schiavaro in the US. Terry was found unconscious in her home in 1995 by her husband. She remained in PVS and the subject of bitter dispute between her husband and parents until the final and eventual removal of her feeding tube in 2005, after which time she died. This would not have occurred in Australia, given that she did not meet the criteria of brain death, in that cerebral blood flow was still present despite Terry having no awareness of herself nor the environment. The longer PVS can persist, the lower the chance of recovery or improvement. Minimally conscious state has a sleep-wake pattern, but unlike VS, has wakefulness in which awareness is indicated. This is assessed by often inconsistent but reproducible, purposeful or voluntary movement, including the ability to follow simple commands, communicate, and brief but voluntary visual and auditory engagement. The PET scan herein shows the brain function present in MCS as compared to the other states. Locked-in syndrome generally refers to patients with quadriplegia, paralysis of all functions and limbs below the neck, including loss of power of speech, but which can sometimes even extend to eye movement paralysis as well. LIS patients have present functionality but an inability to signal in overt form. Generally, LIS patients, however, can communicate by vertical eye movement and eye blinking. Coma is a complete loss of consciousness coupled with no awareness of self nor environment, with reflexive responses only. It does not include medically induced coma. Brain death is irreversible coma which has occurred in the brainstem and or the neocortex. It is easily distinguished on PET scans which show a hollow skull phenomenon, as herein, which represents no brain activity or cerebral blood flow at all. This table sets out an overview of the functionality of arousal, awareness, presence of sleep-wake cycle, motor function, auditory and visual abilities, communication and emotion in the various states of consciousness. There are some studies which suggest that patients can transition back and forth between VS and MCS, however there is yet to be consensus on that issue. Where brain death has occurred, as confirmed by medical practitioners, making end-of-life decisions relating to turning off life support must be made. So who makes the decision to pull the plug? Media often portrays that is the next of kin's sole decision. However, the reality is that the decision to pursue or continue treatment or pull the plug is made by consensus between the substitute decision maker, often the next of kin, the family where it's applicable, the intensive care team, and other medical professionals that are involved in the care and treatment of the patient. In particular, consideration is given to benefits and burdens of treatment, as well as, if known, what the patient's wishes were. Where agreement cannot be reached, mediation or legal determination is sought. Medical decisions are made regarding withdrawal of treatment where brain death has occurred. However, the timing is made in consultation with the patient's family. Death has been determined and life support has been withdrawn. Family and loved ones should be briefed as to what will occur. Support, both emotional and practical, should be provided. Access to spiritual leaders, explanation of the dying process, what to expect and what will be done, along with reassurance and compassion should be provided by all medical practitioners. Physical signs of death, such as noisy breathing, shan, strokes, breathing, and the death rattle, can be quite distressing. The family should be advised that irregular and noisy breathing patterns or the exhalation of breath following cessation of the heartbeat is a normal reflexive action and not voluntary or purposeful breathing by the patient. Likewise, the Lazarus sign may be misinterpreted by the family as the patient trying to communicate. It is vital that the family is provided with explanations of these physical signs and sedative or analgesic medications be administered to relieve the distress of the patient and the family. Removal of superfluous monitoring devices and tubes should be done to minimise distress for the patient and the family. After death has occurred, families should be provided with sufficient time with the deceased, and in the case of child death, the parents should continue to be involved in caring for the patient. Staff should continue to provide reassurance that the patient will be treated with dignity and respect. Follow-up, grief and bereavement services, along with practical assistance, should be provided to family. In particular, what happens next, contact with coroner and funeral services, etc., should be covered with the family, both in verbal and written forms. The ANZIC's framework for brain death determination and end-of-life care should be adopted and integrated into operating procedures in all end-of-life care facilities. Nurse liaison officers should be mandatory and provide a one-stop shop for families to get accurate information, ask questions, find answers, express distress, and find support during end-of-life times, which are times of extreme stress and high anxiety. My father spent some time in CCU prior to having his life support removed, and nurse liaison officer provided some of these services, but was not privy to the medical conversations with various medical staff. It was somewhat overwhelming given the distress we were experiencing, and with hindsight I can see that we were not clear on why things were being decided and by whom. It was daunting and scary. A national protocol involving end-of-life operating procedures and a dedicated nurse liaison officer with specific duties would have alleviated these issues occurring. The determination of brain death is highly bound by medical assessment of behaviour and neurological test outcomes. This should be conveyed to families and bound by a national framework based on the ANZIC's recommendations. This standardised care would circumvent uncertainty, minimise complications, and provide a source of comfort in knowing everything that could be done was done for families of dying persons. A nurse liaison assistant would assist in providing a one-stop shop source of information and provide a go-between for families and staff in order to minimise oversights, ensure accurate information delivery, and provide homogeneous end-of-life care plans. Thank you for listening to my presentation.